Ohio Valley Healthcare District Hospital Corporation Finance and Audit Committee, regular meeting for October 28th. I'd like to call to order. Rosie, would you do a roll call?
Yes. Julie Peterson? Yes. Jessica Dixon? Yes. Mike Russell?
Yes.
Chair Pimentel is absent, and Vice Chair Gallagher.
Present. Are there any agenda modifications? Hearing none. Public comments on matters not on the agenda. Are there any raised hands online?
Not seeing any raised hands.
Any public in the room? No. Any additional raised? Anyway, no public comments. Close public comments. Comments from committee members. Hearing none. Agenda includes minutes. You read, Rosie's any additional stuff need to happen about the consent?
No, we just have the one item, the minutes approval from September 23rd.
Any additions or corrections?
Do not believe so.
Do I hear a motion?
I'll make the motion. I'll second motion.
Second.
We have Jessica Dixon second that one?
Yes.
Okay, thank you. I'll take roll on that item. Jessica Dixon? Julie Peterson? Yes. Mike Russell?
Yes.
And Vice Chair Gallagher?
Yes. Discussion items. Rosie, are there any public comments?
Not seeing any hands raised online, no hands raised in the room.
Any board comments? Okay. I think we'll go to you. Financial performance.
Okay, great. So for the month of September, we had a $1.86 million loss. Again, the issue was net revenue. We had very low volumes for the month. Our average daily census was around just shy of 28 against a budget of 34. So we were shy in patient days by about 186 days. We were 56 admissions below what we had budgeted. It really resulted in a $3.5 million deficit on the net revenue. We also saw that the payer mix was not as favorable in September, and what I'll show you in the stats is where some of the service mix was a little less favorable, with fewer deliveries and surgeries, robot-assisted cases being down, and a little bit of decline in the non-ER outpatient visits. Expenses favorable by $1 million, but as we've talked about before, that doesn't always translate to the loss of volume due to poor staffing. So on a year-to-date basis, we're behind budget on the net revenue side by almost $26 million. It's resulting in an overall loss of almost $16 million year-to-date through September. Overall, it's the same stories with the volume being unfavorable. We're about 17% below on a year-to-date basis in patient days, so that's about 16 patient days. We're about 400 admissions below where we plan to be. A few things going on the expense side. You can see that most of the expenses appear favorable, but not to a volume-driven basis, just to a fixed budget. So we have, numerous areas in salary and wages that are unfavorable to the flex budget due to poor staffing. We have some overages in our contract labor because we have some continue to have leave of absences in certain areas. We've got some hard-to-fill positions, especially when it comes to, like, nighttime coverage for ICU, emergency, tele. Some of the other things we've seen, this, kind of relates to what we're seeing across the country, that, like, food costs are up for our cafeteria. Certainly some of our supply costs when it comes to implants are up. We have some unfavorable higher, pharmacy costs with higher drugs and, the work that we've been doing on 340B with a consultant. Next slide. So this is that slide I've been showing that kind of just breaks apart where the net revenue variance is very similar to the last few months that we've been showing this. The big three being what the service mix looks like, the volume, and kind of overall collections. Those are pretty evenly split in the 20 to 28% range. Case mix, our case mix hasn't been meeting where we had budgeted, and so that has about a 6% impact to this, and then bad debt was about 8%, and the rest being our swap and dish payment. So that's really what makes up the $25 million. Just drilling into the service mix a little bit, it's really, kind of, I spoke to it from the other side, but the admissions being down, that's our medical inpatient, deliveries being down from OB, surgeries are down slightly. The fact that we had budgeted for some outpatient surgeries and cath lab and things that we don't have happening yet, those are also. So here's a quick look at the statistics for the month. I've kind of touched on a few of them. Admissions being down 18%. Length of stay was basically right at budget. Case mix a little lower than planned. Inpatient surgeries were down about 9 inpatient, just 3 on the outpatient, but a little bit of the mix of outpatient can also play into these lower net revenues. And then our outpatient visits, the non-ER, I think this is probably the first month that I've seen this budget, and so they were down about 5% to budget. So year to date, it's pretty much been the same story every month that we've seen, with the admissions being down, somewhat weighted by the fact that we had planned on some PEDS admissions and paused that program. Deliveries are really right at budget for the year. Inpatient surgeries are actually higher than we budgeted, even though they're below this month's budget. And then the outpatient surgeries have been below budget, and a lot of that is driven by the cath lab being a part of the outpatient surgery budget. ER visits rebounded a little bit this month from being down last month, and they're just down a bit from about 7% for the year. From a payer mix perspective, payer mix was unfavorable this month. We saw a pretty significant drop in the commercial mix this month. We were just down at a little over 12 for the month, and last month we had been at 17%. So that had a significant impact on the net revenue. We are seeing some increases in the managed Medicare, and then Medicare was also up this month, a little bit offset on the Alliance and Medi-Cal side. And to the outpatient, outpatient was pretty similar to previous months. Commercial was basically flat, up about 0.2%. The Alliance had bounced back up a little bit from last month, and everything else is relatively flat to prior months. So taking a quick look at just kind of the overall initiatives that we had planned for and where the kind of largest pluses and minuses are. We had the favorable results. We have been doing pretty good with reining in our supply expenses related to volume. Still always working there, just because we do use a lot of supplies here. But that is producing a favorable impact to how we had budgeted for it. Our new primary care, Dr. Robinson, ago, and his NP, Dr. NP Clausen, they've had good volumes and producing better than budgeted for the year, and we've been continuing to grow our 340B savings. We also have the cost avoidance items of not doing any leadership bonuses or leadership retirement plans, of not having the cash to do so. On the unfavorable side, the largest areas are, the lack of the cath lab volume, the fact that we paused the pediatric volume that we had planned for, and then the fees that we're paying with the radiology group. As we've gone through our radiology transition, those fees are higher. We're still in the early stages of the most recent radiology group coming in, and now that their collections are ramping up a bit, that will help, reduce some of the just pure expense to us, because it will be offset by their collection. Next slide. And then, one final slide just to talk a little bit about cash, just to give an update. We are continuing to be challenged with outstanding accounts payable. We have a lot of aged AP, and so every week we're looking at our payment plans, the critical vendors, which vendors are needing some payment to release orders so that we can avoid credit holds or delivery holds. And it really is boiling down to not having enough volume to cover what we would consider an ideal AP disbursement, so a little bit further behind. We have many phone calls and emails and activities with the vendors to either renegotiate payment plans or spread them out a little bit, and then we're continuing our work to look for other funding sources. And one of our future or later agenda items here is talking about the one that's coming up with our voluntary rate range program. So that is my report.
Thank you. Rosie, is there any public comment?
No hands raised online or in the room?
Any other comment from in the room? Quick question.
I have a question. You go first.
How's it structured on the radiologist, their fee? Somewhat, kind of like a salary guarantee, as they make more, they get reimbursed less, or what's this broad outline of the structure?
Yeah, I mean, the broad outline is that they have, kind of a guaranteed monthly amount, but as they have collections that offset that, so as they're, now that they've been in place and their collections are starting to build, that helps with the monthly amount.
That answers my question.
I wanted to ask a little bit more about, see if we could dive in a little more to payer mix. Do we know what our payer mix looks like this year compared to last year?
We do.
Okay. And significantly different? I'm just curious about the, your pie chart with the collections, 28% of the unfavorable net revenue is collections. To me, that payer mix, but I don't know if that means something else.
It can be payer mix. There's a little bit of, there can be a little bit of overlap in these. It typically can speak to payer mix. It can speak a little bit to the plans within the payer mix that pay a little bit differently, and then it can also just lost my train of thought of what I was going to say. Sorry, I lost my train of thought. I'll try to come back to that, but we do have, I don't have all the numbers in front of me. As I've been watching this kind of month over month, it has not been at the highest levels, which are like major financial classes of Med-Cal,
Right.
management stuff. It had not been that drastic of a shift.
I didn't think so.
This particular month, like,
Yeah.
that commercial drop was,
Commercial inpatient was
yeah,
a big difference
and-
in September, but not for the year as a whole, it
Yeah.
doesn't seem like.
yeah, as a whole for the year, it hasn't. Some of this is, probably speaks to our valuation processes. We're always kind of continually trying to refine them and trying to understand things that might have been valued at one level in a prior month, and then new information came in. Sometimes that lowers the evaluation, sometimes more times it lowers it than it does. We're also just, this year we took, last month, we did the bad debt cleanup, so we moved a lot of AR off. We're continuing to try to work through what we consider aged AR, more than 90 or 180 days, because I think that's typically the drag on collections here. So as we're working through things with Guidehouse, that impacts the AR valuation to a certain extent as it gets further out age. But as we're working with Guidehouse, we're really trying to get a sense of, is this being worked? Is it truly collectible? Should we be making a different decision now versus waiting until it hits the 365 mark?
I have one other question, which is about volume. I've heard that other hospitals in the area are, really for me, try to catch up. The inescapable conclusion is federal government's anti-immigrant. But do we think there are other factors?
I think the overall fear of health insurance premiums, and there's a lot of uncertainty around that right now. People are seeing that their healthcare expenses are about to go up. I think that does impact people's decision making to avoid healthcare in general, because things are going to be expensive, right? If co-insurance is about to go up, I know that it's going to be more out of my pocket to have to do this elective case that I really should get done, but maybe I'll wait and see if my insurance gets better in 2027 or something like that. But I think that's part of it too. The immigration piece definitely has a piece of the Sahara Valley where we are, and I think just uncertainty about the economy definitely keeps people away from the elective stuff, which tends to be how hospitals get their revenue, right? That's the stuff that can be put off.
Yeah, I think that there's, kind of speaks to the economy, but other things are costing more.
Everything,
Price
right.
groceries or,
Right.
childcare, things like that are really starting to hit people, especially people who have either somewhat displaced with work or had uncertainties around work. I think that is, that tail.
I'm assuming it's probably going to be bundled in this collections bucket here, but what I've noticed in the last month, there's a couple different things happening in our, we think about collections right here, we think about what payers are, on the patient side, I've observations at an increased level of charity applications, also volume. We've noticed that patients that are either on payment plans or rate in which they're satisfying their outstanding balances, even if they're not. Those are indicators to me that there's stress in the environment where they're unable to pay or less willing to pay balances that are owed. This month, and this last comment's a little more anecdotal, but seems to be more patients who are on existing payment plans that are ceasing payment, missing payment. see if that's flash in the pan or
Right.
something that, will become more of a trend.
It would be interesting to quantify and trend one or two of those.
Sure.
If there really is a trend there, the board, I think, would be, I think it would, for me to be able to speak to you as I'm out in the community about some of the other challenges that we're facing in healthcare.
Okay.
But
I can,
I appreciate that.
I can put
Especially
together like
the
a,
volume of charity care applications, like on a quarterly basis or a monthly basis or something.
yeah, I'll work on putting together a packet.
Rosie, any other comments? That's fine. Julie, I think we go back to you for budget update.
Actually, we're going to go to Vanessa for budget update.
Okay.
You guys hear me well enough?
Okay, ready when you are.
I'm good. So Rosie, will you be sharing the PowerPoint or?
Good. Do you see it, Vanessa, or no?
No, I just see all your pretty faces, so I can follow along with my own side, but I don't see it being presented.
Oh, it stopped for some reason.
Let me try again.
More than happy to look at you guys. I can look on my own copy, but it helps to follow along.
It was sharing.
Okay, I see Julie's, yeah, I see you kind of navigating out of the financial performance packet, Rosie.
It says you were sharing.
Okay,
Okay, there we are.
okay. Sorry about that.
No worries, it's all good. So bear with me. Feeling a little under the weather, so I have to stop and pause to cough on the side. I apologize. So kind of, looking at our 2026 budget volumes, the base volumes that we talked about or we mentioned last month was 10% reduction in admissions, 9% reduction in days, 2% reduction in emergency room visits. Kind of as we've seen trended, a 1% increase in our non-ER outpatient visits, hopefully an increase in surgeries and an increase in deliveries. So this is kind of an overall volumes in terms of what's driving our 2026 base volumes that drives both our revenue and our expenses. Next slide, Rosie, please. So kind of looking at that, we are showing kind of our net operating revenue 24-25 annualized, which is again 2025 January through July annualized. And then to the very right, which is what we're going to try to focus on, is our 2026 budgeted. This is exclusive of HR1 at the moment and is inclusive of Quoth 9 at 75%. So you'll see here that, our labor and benefits obviously is going to be less than we project for 25, again, driven by the drop in volumes that we're projecting for 26. Another thing that probably sticks out is that our other expenses jumps up pretty dramatically, and that is because that is where the Quoth 9 fees lie. And so that we will see the increases there. So kind of looking at our base volumes exclusive of, at this point of view, HR1 and any initiatives, we're projecting a negative EBITDA of about negative 1.8 million. Stop there. Any questions thus far?
Yeah, I think I'll just pop in real quick and kind of reiterate what you just said, that I think it's
Yep.
worth repeating that kind of the reason we led with kind of some of those volume assumptions is sometimes it seems counterintuitive to be budgeting less labor in a future year, because you always have the CBA increases and things. But we are budgeting enough of a volume, less of a volume projection that it does result in some labor savings and brings down supply expenses a bit. And as we're going to go into the next slide, you'll really start to feel how much weight both the Quoth and the HR1 are going to have on next.
Thank you, Julie. Appreciate that. I'll stop there if there's any questions before we move on to the next slide. Okay. So kind of paying attention to, looking at left to right, you'll see in the left, we kind of do some high level summarizations, looking at consolidated, focusing on the net patient revenue, the total net revenue, the expenses, delineating out, what's our gross revenue, the deductions, and then to Julie's point, kind of isolating, what Cloth 9 looks like without it, with it at 75%, the impact of HR1, and kind of getting to another view of our base budget. So, if you look at our 2026 base budget without Cloth 9, you'll see there that we really get to a negative 13 million EBITDA. And again, to your right, you'll see why that is that in terms of our cloth dish, even at 75%, it was adding $18 million. And then again, to the expenses, it would increase our expenses from the 3 million to the 7.1. Again, at cloth 9 being at 75% in terms of kind of right now, we're not sure what it is. And so 75% is what we're kind of slating it to be. And then in terms of the impact of HR1, we kind of get to the midpoint of the estimates. The estimates ran from a loss of 4.2 to a loss of 5.6. We kind of hit the midpoint and are estimating the impact of that to be about 4.9 million. And so what we wanted to kind of accomplish here is that if you add some of the pieces, so you start with your base budget 26 without Cloth 9, you include it at kind of our hope of that being at 75%. Then you add our HR1 impact, you end up with a negative EBITDA of negative $6.7 million. And so to Julie's point, you can kind of see how impactful Cloth 9 is, and in terms of how it impacts the budget, depending on kind of where that lands eventually. I'll stop there if there's any other questions before I move on to the initiatives and IGT. And so when it comes to the, oops, sorry, Rosie, back one just a little bit. Just wanted to kind of again show that, we're still looking at other initiatives, but the biggest one that kind of has most impactful is the IGT. So in terms of that, we estimate it to be about $5.4 million in terms of additional revenue. But again, along with that comes the expenses aside to it. So the IGT essentially nets us about 2.3 to the EBITDA line. So that if you kind of start with our base budget inclusive of HR1 impact, and then you add the IGT, it helps to kind of reduce that 6.7 million EBITDA loss to about 4.3 million. And then I'll stop there to see if there's any questions.
I think this is, where we're kind of sitting from a current operations plus, the estimates, high-level estimates around HR1, our IGT programs that we're entering. And so, the question is going to become, do we have initiatives, how much of initiatives that we're looking at are going to be able to offset this $4.3 million loss? We're certainly work that we're doing around adding a new MRI and a new CT. Those are probably first quarter deliverables that we still need to project out, kind of what volume, what increases, what expenses do we expect, what will that net? Again, where's the cardiovascular program going? Things like that. The one piece that is not anywhere in here, and at this point we don't have anything to put in here, would be, cost of a strategic partnership. And, we just don't have enough information to be able to spell out what that could look like, what it could cost, what it could benefit. So it's very likely that we will go into this budget with that not included. This would be, if we continue down this path on our own, this is what things look like.
Can you remind me in this iteration, maybe Vanessa, this iteration of the budget, what do we have for our new orthopedic surgeon? We
don't have anything new. We have just the overall base assumptions of how we've been doing this year. So that's some of the work that's being done, with Lupe to kind of try to carve out a ramp-up / growth potential.
Great.
Yep, yeah, exactly what Julie said, Steve. That's kind of the next iteration. The volume you see here is kind of the replacement volume, but the next piece for us to kind of review again and work with Lupe is to understand the growth impact of those new physicians.
You're actually that's a good lead-in.
Yeah.
I always come back, but to the next slide.
Yeah, I think Steve jumped the gun. So again, there's a number of initiatives under review that we haven't quite quantified yet. So this is again the cath lab looking at, we're starting with new physicians, like understanding kind of what's there in terms of what we can quantify and build into the budget for 26. We're still trying to gather information and understanding what's the growth in the MRI CT volume in terms of, again, what's the additional volumes that we're hoping to get, the reimbursements, the revenue, along with the added expenses associated with that. Steve, you kind of talked about this too. We're working with Lupe now to understand the volume growth, not just for the orthopedics, but also the additional physicians of primary care and the general surgeon. To Julie's point, something we haven't yet quantified is it'll be, as we learn more about it, is that any strategic partnerships, understanding, what that will help in terms of how to incorporate that into the budget for next year. And then another one, which is kind of an overarching thing that we always are looking at every year, is to understand what revenue cycle improvements that we're still trying to understand and quantify that we can then also add on to our estimates for next year's budget. So I know I went through that list fairly quickly. So I'll stop to see if anyone has any questions in terms of, the overall base budget that we've put together thus far. There's always further refinements. We've done refinements looking at labor standards, things like that, but we're continually to just kind of ensure that we've captured everything, working with the individual department leaders to kind of get us the right quantification for these initiatives, along with any expenses that they also anticipate. So we've made great progress in terms of our last month's budget, but there's always more things to do as we kind of learn more about initiatives in other parts of the budget. I wish I had better news, but it's the fact that the Quaff 9 is really, really kind of driving our EBITDA to be looking good, but because the scenario where we don't have it is quite dire.
Rosie, is there any comments or questions from online?
No hands raised online.
Anyone else in the room? I have a couple of questions, Vanessa. These are in some ways kind of operational detail questions. Steve, the general surgeon, is that the colorectal surgeon from up the peninsula who showed an interest a month or two ago?
No, he's here. He's doing call a few days a week.
Yeah.
He's taking 6 or 8 days of
Okay.
call in
Somebody else.
November, but this is the new general surgeon who will be joining us from Southern California to the Coastal Healthcare practice. So Dr. Nolan's new part.
My other thought about this in terms of initiatives, I know our sort of day-to-day operational issues are not usually considered initiatives, but to me, mother baby has been a consistent loss. Might it benefit from having that sort of focused attention? It hasn't already. And same for surgical services, that to me we were turning cases away for a variety of reasons. Might either or both of those services benefit from being considered a kind of overall initiative?
Yeah, surgical services for sure, and we'll actually share some good news at the board meeting that the foundation has completed its $6,000 fundraising effort to get 2 new towers and do renovations into our operating room. So we look forward to announcing that tomorrow night and getting that work done so that we can fix it here.
Sure.
So yes, the operating room is definitely, and take a look at, labor and delivery is one of those areas where less volumes are there. We're at those minimum staffing ratios and requirements that they're doing it as they can, but we gotta keep looking at those labor standards and make sure that
only thought I've had over the years is to try to recruit and start a private practice, a big practice to attract additional patients. And that's incredibly expensive. I thought it might be measured and fundable as an expansion of service.
I don't think it would be unless the expansion of services included some sort of building or property and investment. I don't think we can use it for
Tenant improvements.
we could do tenant improvements, but in terms of like expansion of salaries or anything like that for new docs, we wouldn't be able to do.
No, not so.
Correct.
Okay.
And having said that, we do have some conversations.
Okay. Thank you. Next item, back to you this time, Julie.
All
The
right.
memorandum, MOU with the county.
Okay, kind of give you, as you know, we have signed up with, DHCS and, the Alliance for the Voluntary Rate Range Program, where our first payment of just shy of $600,000 is due in November, and that DHCS takes that and combines it with other money to the feds and to return a greater portion back to us through an intergovernmental transfer, which would bring back about $1.4 million, so a net of about $800,000. And so we've been working with the County of Santa Cruz, who has agreed to basically fund our initial $600,000 payment to give us basically a short-term cash reprieve, and then when we actually got the $1.4 million, we would pay them back the $600,000 and then keep the $800,000 less the payment that we'll make to our consultant who has basically put this program together for us. So we have an MOU that would need to be signed with the County of Santa Cruz to just outline this agreement that we will have them funded up front and that we will pay them back, and that it meets all the terms of how this program works. And so this is really just a request for approval to execute that agreement.
And that's something that comes to the board tomorrow night for approval.
Yes.
Not something we need to, it's just informational.
Correct.
Thank you. Any other questions or comments?
What's the timing of that Fed payment?
It should come back to us by February. And then we will basically, put it in our IGT fund that we're growing so that we have a secondary IGT where we need to make the payment in April to get back funds in June.
I think we're through the agenda. Thank you all.
Thank you.
We're adjourned.
Thank you.